Good morning. Please state your roll number.
Good morning, sir. My roll number is 1257.
Wonderful. Okay, go ahead. Please present your formulation and management plan of your patient.
Sure, sir. Sir, I am presenting the case of Mrs. H. She's a 28-year-old lady. She's a married engineer. She works in a private company based in Bangalore. Premorbidly, she has traits of pervasive feelings of apprehension, the belief that she is socially inept, and with avoidance of social situations, which are suggestive of anxious avoidant personality traits. There is family history of depression in first-degree relative and bipolar affective disorder in second-degree relative, with history of completed suicide in one of the second-degree relatives at the age of 35 years. Married life is of 4 years duration with primary infertility and interpersonal conflicts with the in-laws. She is currently presented with an episodic illness since 12 years, with the current episode lasting for the past 3 months, characterized by pervasive low mood, anhedonia, easy fatigability, decreased sleep and appetite, weight loss, early morning awakening, decreased libido, with a 2-week duration of symptoms characterized by nihilistic delusional belief that her intestines and kidneys are withering away and that her insides are hollow.
Well done, Dr. Sachin. It was a very good presentation.
Thank you so much, sir.
Going to ask you a few more questions to proceed with our Viva. Dr. Sachin, can you tell me what are the Kane criteria that are present in your case?
Yes, sir. So, as per the Kane criteria, treatment with different classes of antipsychotics at equal doses of 1000 milligram per day of chlorpromazine equivalent should be there for at least 3 periods of 6 weeks in last 5 years without significant clinical improvement. So in my patient,
can you mention any differences between this and the modified Kane's criteria that is currently in vogue?
Yes, sir. So treatment according to the modified Kane's criteria by Conley et al. So they say that treatment with different classes of antipsychotics at equal dose of around 400 to 600 milligram per day of chlorpromazine equivalents at least 2 periods of 6 weeks in the last 5 years without significant clinical improvement.
Yeah, but basically the differences that we need to highlight are that the number of antipsychotics that have failed were decreased from 3 to 2, and the dosage equivalent of chlorpromazine has also been decreased from 1000 to 400 to 600 milligrams.
So now that your long case presentation is over and also the discussion, I would like to ask you some more questions so that you can get some extra brownie points. So can we go ahead?
Yes, ma'am.
Yeah. So can you explain the term obsessional neurosis?
Yes, ma'am. Sigmund Freud coined the term obsessional neurosis. This disorder was thought to result from a regression from the Oedipal phase of the anal phase with its characteristic ambivalence.
Okay, good. So what defense mechanisms are commonly associated with OCD?
Ma'am, isolation, undoing, and reaction formation.
Good morning. I already interviewed you and discussed few of the things. I would like to clarify few more things regarding the unusual experiences. Can you please tell me more about the unusual experiences you are having?
Okay. I started hearing some voices. They've been going on for about 2 months now. Only I am hearing those voices. Everybody else in the house is saying that they can't hear them. I don't know if they're lying or they're telling the truth.
Okay. So it must be difficult for you, right? So since how long you are hearing these kind of voices? Can you tell more about this?
Maybe last 2-3 months, maybe.
What made you think about stopping the injection?
Yeah, as I told you, I mean, it's my friend actually who patched me through to this place, and so I came. I didn't even want to, kind of start these injections in the first place. It was my friends that initially they said that it would kind of help me with my sleep issues and some stress, and so.
So you're suggesting that it was your friend who made you take the injection, but later you continued it because you liked it.
Yeah, you can say that.
And also that after some time you realized that you didn't like it, but you had to continue just because you didn't have to suffer the pain. Am I right?
Yeah. You're absolutely right on that one.
Any other reasons to stop injections? In the current interview, it was evident that patient is in preparation stage for opioid use, but in contemplation stage for sedative and hypnotic use, wherein you can see the ambivalence in the need to stop, but unwillingness to intermittently considering the sleep disturbance as a reason. Patient is in pre-contemplation stage for tobacco use at present. Patient's locus of control appears to be external, considering that his attribution to initiation seems to be towards friend, and also the need mostly is related to reduce the family stress rather than